Just ask you to quickly turn your cameras on so that we can make sure we are seeing who we expect to be seeing. There's a lot more people today, so it's just going to take me a second or two more just to flick through everybody. Okay. So, as I said, today's session is being recorded, so if you can ensure that you keep your mics silenced. There's going to be opportunities throughout the presentation to put questions in the chat section. You should all have a chat button in the top of your screens. If you do need to ask a question that is pertinent to the bit that's been presented and it can't wait, either old-fashioned, put your hand up and I'll watch out for you, or there is a little hand emoji on Zoom that you can put up as well. Said we'll be doing questions at the end, but raising hand, I will try and keep an eye on everybody. So without further ado, I'm going to hand over to the Reverse Rett CEO, Rachel Stevens, who's going to introduce our guest speaker today.
I'm sorry to disappoint everybody. I am not, in fact, Rachel Stevens from S7. I am Rachel Stevenson, CEO of Reverse Rett. And I think I know most people here, but we also are glad to be welcoming people on YouTube later on after this is recorded. I am a parent of a daughter and a stepdaughter with Rett syndrome, both of whom are now adults. And we're really glad to have everybody with us today. The speaker that we have today needs no introduction to most people in the Rett community. Dr. Dan Lumsden is consultant in pediatric neurology and complex motor disorders at the Evelina Children's Hospital, where he has been running the Rett Clinic now for, must be about 5 years. Is that right, Dan?
Yep. Mm-hmm.
Yeah. So at the Evelina Rett Clinic sees patients from all around the UK, patients under 16 on referral. And so if anybody who is watching this video is looking to be referred, please do contact us after the session and we'll help you, give you the right directions of where to go to get support with that referral. So Dr. Lumsden, thank you so much for being with us today. Thank you for giving us your time. I know that you're very busy. And without further ado, I'll let you get on with talking about emerging gene therapies in Rett syndrome.
Fantastic. So thank you very much for firstly the very kind invitation to talk and that introduction. Let me just start my slideshow. And can I just check that that has popped up onto the full page view? Perfect. I can see some nodding. I can see some faces and some familiar faces. That's lovely to see. So as Rachel said, I'm one of the pediatric neurologists at the Evelina, and I have the privilege of being the clinical lead for our Rett service. So I had the privilege of having the service handed over to me from Dr. Hilary Cass when she retired a few years back. And had you told me when I took over the service about 5 or 6 years ago that I would be talking about not just one company, but 2 companies actively undertaking gene therapy trials just 5 years later, I would have said that you were crazy. So these are incredibly exciting times, and genuinely it's a real privilege to be involved in any kind of way to help with moving things forward. I do just want to acknowledge a few disclosures at the start, and I think really the pertinent things for these talks are around some paid consultancy that I've undertaken for Neurogene, and also my involvement with Taysha in terms of the planned clinical trials in the UK. Nothing I'm saying today is information that's not already in the public domain, and anything I say is my own view and opinion, so this is not kind of representing any of these companies' views. So just to kind of outline what I hope to cover for the remainder of the talk, a little bit about what Rett syndrome is, but hopefully not taking too long around that. Talking a little bit around the link between the MECP2 gene and Rett syndrome. A little bit around the principles of gene therapy for Rett syndrome. Talking then about the gene therapy trials that are not just planned, but are actually underway. And then having a little think about what this might mean for the future. So many of you will see this picture. This is Andreas Rett, the gentleman from whom the term Rett syndrome is actually derived. He's a pediatric neurologist that worked in Austria, and the apocryphal tale is that he literally saw in his clinic room one morning 2 or 3 young ladies with a reducing head circumference, a very characteristic pattern of breathing, and hand stereotypies, and realized that this was more than chance, there must be a syndrome there. We now know that Rett syndrome is one of the commonest genetic causes of learning difficulties in females, and estimates of its incidence are about 1 in 10,000 to 1 in 15,000. And the clinical definitions, how we define Rett syndrome, have changed over time, really, I think, reflecting our increasing understanding over the years. More importantly, particularly when we're thinking about gene therapy, a very strong association with the MECP2 mutation has been found, but it remains a clinical diagnosis. And I think that's an important thing to flag at the start, because there are young people with a diagnosis, very appropriately, of Rett syndrome who do not have mutations in the MECP2 gene. And unfortunately for those young people, gene therapy targeting the MECP2 gene is not going to offer any benefit. So thinking about the Rett syndrome and how we define it. So importantly, this is a condition where we have a period of regression followed by a period of stabilization. We have major criteria, and they're essentially a loss of gained hand skills, a loss of acquired speech, some or all of it, the development of very characteristic midline hand stereotypies, and then the development of gait abnormalities. People will be aware of the minor criteria. I won't read this list out here, but the key things are around things like teeth grinding, the breathing disturbance, and some of the issues with small and very cold hands and feet. And then importantly, for a diagnosis, certainly of typical Rett syndrome, we have some exclusion criteria, that of a very significant neurodevelopmental delay before 12 months of age, or evidence of brain injury or another abnormality that might account for the clinical picture. And really, we would say that a young person has typical or classical Rett syndrome if they have the 4 major criteria and none of the exclusion criteria. Atypical Rett syndrome is where someone doesn't tick all of those boxes, so they might have only 2 or more of the major criteria, but they have the minor criteria and they may have the exclusion criteria. Now, these definitions were last agreed upon by the clinical community back in 2010. I think anyone that works with young people with Rett syndrome would recognize that these are entirely artificial divides. And actually what we would see is a spectrum of young people with varying extent of the features of Rett syndrome. And actually, interestingly, we are now recognizing quite a few young people for whom they don't appear to have a clear period of regression. But it's important for the purposes, certainly, of the initial clinical trials, that they will concentrate on people with typical or classical Rett syndrome. So it is important, whilst I will say in one hand that I think this is an artificial divide, it's important that we're aware of it and we recognize it, because these will be anti-criteria, certainly into the initial trials. So the MECP2 gene. So we know there's a strong association. So if you have a young person who meets the criteria for typical Rett syndrome, more than 95% of them, so more than 19 out of 20, will have a mutation in the MECP2 gene. For young people with atypical Rett syndrome, it's probably about 75 to 80%, and there's a very big range of ever-expanding genes that we know about now that can also cause an atypical Rett syndrome picture. The MECP2 gene is found on the X chromosome, and that helps to explain why it predominantly affects females. And it's a very complex gene. So this is what I call a complex Epstein gene. The way it works is the activity of the protein it produces affects a little bit the level of expression of a wide network of other genes. It's expressed in the brain, and that's very important, of course, for the problems that it causes with development and neurology, but it's also expressed in other tissues of the body, including the heart and the bones. So don't worry, I'm not going to go through this slide here, but this is just showing those complex range of problems that the MECP2 gene causes. It interacts with a large number of other genes to affect their expression, and that's important for how we think we might approach treating it. There's not a simple mechanism here that you can correct by putting in a little molecule or a little medicine. It means it's a very difficult disorder to treat, and we'll come on and talk about that in a bit more detail as we progress. Now, importantly, when we're talking about genetic conditions, and particularly for clinical trials, are these 2 terms that you may have come across. So people talk about genotype and people talk about phenotype. So genotype is the characteristics of your genes. So it's literally how the genes are spelled out. And when we're talking about a young person or a patient's genotype, we're talking really about the specific spelling mistake and the specific gene that's caused a problem. The phenotype is the impact of that. It's the observable characters. So what does that young person look like when we have a problem in the gene as described? people will often talk about genotype phenotype correlation. So if you have a genetic change, how can you use that to tell you exactly what that young person's going to look like in terms of their clinical features? And for Rett syndrome, it's an imprecise correlation. So what do I mean by that? This is a graph taking data from a couple of large studies. We have different mutation types along the bottom on the x-axis, so different spelling mistakes in the MECP2 gene, and then we have different severity scores. And what we can see is that there are those gene changes on the left are typically associated with lower severity scores, those on the right more severe, but actually there's a big overlap and there's a big range for each of these. So when we have a single gene change in a young person, we can't really use that to predict with any great certainty what the impact will be and what the clinical picture, the phenotype will look like. And that's important when we're thinking about how we measure the impact of gene therapy, particularly in children. So if we're thinking about how we might approach the treatment of any condition, the simplest thing for us to do is to treat the symptoms. So if we're thinking about young people with Rett syndrome, we might use medications to treat the symptoms of a seizure disorder, an anti-epileptic medication, or we might use a medication to help regulate their breathing or help with anxiety or the like. The next step down is the disease mechanism. So actually looking at what's going on in the cells of the brain or the body, looking at the problem, the process that's gone wrong, and doing something to correct that. And because we have this complex interaction with what the MECP2 gene does, we can't simply correct this. Now, there are conditions we can. If we've got a genetic problem which causes an enzyme deficit, you can replace the enzyme. And if you correct the mechanism, you improve the symptoms. But that's not an option for us when we've got young people with Rett syndrome. So what we're left with is gene therapy. If we want to do more than treat the symptoms of the disorder, we actually have to replace or correct the faulty gene. And that's what we're going to be talking about today. So this is probably the most overplayed video of mice that I've got, but it's a very exciting video because this is really the first demonstration in an animal model that if you have a problem with the MECP2 gene and you correct it, the symptoms improve. So the mouse on the left is the mouse who has been engineered to have Rett syndrome. And it doesn't move much. That's kind of the point there. But what we can see is there's a paucity of movement. It doesn't move around very much, but there is a shakiness and a tremulousness. And what Professor Guy's lab demonstrated is that if you correct that deficit, if you turn the MECP2 gene on, the mouse gets better. And this is the same mouse after the gene has been reactivated. And you can imagine how exciting this was as a clinical research community to see this happen. And what's particularly exciting for us is that it doesn't seem to matter at what age you reactivate the gene function in the mouse. If you activate it as a child mouse or as an adult mouse, you still see improvements and benefits. And for us working with young people with Rett syndrome, that's very important because it suggests to us that at any point in the life of a young person, or as a child or an adult with Rett syndrome, if we can correct the problem with the gene, if we can turn the activity of the gene back on, we can see benefits and improvements. And we're starting to get some early signals and some glimmers of that from the 2 patients who've already had the gene therapy, which I'll talk about towards the end of the talk. Oh, we'll go past that. So there's lots of considerations when we're thinking about gene therapy for Rett syndrome, and I'll cover some of them, but far from exhaustive. So the first challenge is, how do we get the gene therapy into the brain? Then the question is how we get the amount of gene action that we deliver correct. And I'm going to call that the Goldilocks principle. Not too much, not too little, just the right amount. We then have to make sure that when we put the gene into a young person, that it's tolerated and it doesn't cause problems. We then have to think about how we measure outcomes. And then we have to think about how we understand the impact that has on a young person for their individual natural history, as it were. And I'm going to talk really about the first 3 of these. So how do we get the gene therapy into the brain? Now, your brain is a very protected part of the body. There is a thick membrane, several membranes actually, that make up what we call the blood-brain barrier. And what the blood-brain barrier does is it stops chemicals from easily getting into and out of the brain. And it means that the brain is a very tightly controlled and regulated environment. Now, that's essential because if we think about how things like our sugar levels go up and down in our bloodstream, if the same thing happened in our brain, we wouldn't be able to function. You know, when the blood level went down, when the glucose level went down, the brain wouldn't like it. And when it went high, it wouldn't like it. And so we seal away the brain, and we have then a barrier that stops things from getting into it. But that means that if we want to deliver a drug, or particularly if we want to deliver a gene therapy, we have to physically deliver it past that barrier and into the nervous system itself. And really, there's two different ways we can do that. One way is with what we call a ventricular catheter. And what that's doing is taking a tube, it's a neurosurgical operation, and you are passing the tube through the outside of the skull into the fluid-filled spaces in the middle of the brain that everybody has, and you're then injecting the gene therapy into that area there. And this is the approach that the proposed neurogene study is going to take. The other option is, rather than putting in at the top end, as it were, is to go at the bottom end and perform a lumbar puncture to feel for those gaps between the spine, insert the needle between those gaps, and deliver the gene therapy directly there. And this is the approach that has been trialed by Taysha. Both of these have pretty robust evidence in animal models that they are good ways of getting the gene in, and there's no evidence that suggests that one is better than the other. Now, how we then get the gene therapy into the cells of the brain. Now, there are lots of different ways we can do this, but essentially the way that the two proposed gene therapy trials are proposing is to use what's called a viral vector. Now, viruses are nasty things usually. We don't like to give people viruses in medical practice if we can avoid it. But what viruses do is get into the cells of the body, and they install their own DNA into the DNA of each cell, and then use those processes that the cell normally has to replicate and to produce proteins. And so that's how the gene therapies are proposed to work. The virus takes the fluid that you've injected into the fluid space around the spine or into the brain, and then it delivers the gene therapy into the actual DNA of the person that's receiving the therapy. But it's important to note that the virus is a foreign substance, it's a foreign protein. And so this is why we need to think about immunosuppression, as we'll talk about. So we talked about there. Then what about then getting the amount of gene action right, the Goldilocks principle? So the challenge with our MECP2 gene is that whilst problems arise when you don't have enough of the function of the gene, you get the clinical syndrome that we call Rett syndrome. If we have too much of the gene, that also causes a problem. And that's a condition that we will call MECP2 duplication syndrome. Now, the clinical features are quite similar, but there are some differences. So Rett syndrome, we typically see in females, not exclusively, but typically. Young people normally have a normal period of early development before a regression. And it says a regression uncommon here. I do apologize. It's such a regression common. Epilepsies is common with multiple seizure types. There's developmental problems. And again, sorry, speech is, developing speech rather is uncommon. For the MECP2 duplication syndrome, in contrast, we see that there is typically affecting males. Development is usually delayed from the start, and it's unusual to see a regression. Unfortunately, young people just don't make that progress early on. Seizures, there's less variety. It's more often generalized tonic-clonic seizures, but then they also go on to have significant developmental problems. Developing and gaining speech is uncommon, and as a separate feature, they have are suspected to have a primary problem with their immune system and are more prone to infections. Well, this is important to us because in delivering a gene therapy for Rett syndrome, in putting a working MECP2 back into the system, we have to make sure that we don't express too much of it, because if we do express too much of it, that will cause problems. Now, it's beyond the scope of what I want to talk about today to explain how the gene therapies avoid this. But essentially, both of the companies and both of the laboratories that they've been developed in have developed a very clever molecular mechanism that's part of the gene therapy that's delivered that regulates how much MECP2 is expressed and make sure that it's that Goldilocks amount. Not too little, not too much, just the right amount for it to have an effect and make a difference. So then how do we ensure the gene therapy is tolerated? So I've said before, we're using a virus to get the gene therapy into the cells of the brain. And the virus means that we're going to be incorporating foreign protein into the body. And the body fights viruses, and that's a good thing. We want the body to fight viruses, but we don't want the body to fight the gene therapy, and we don't want the body to be fighting those cells that have the extra protein. Now, unfortunately, there are young people and there are adults who have received gene therapy using these viral vectors, where the body has reacted to the virus and it has caused significant problems. And very sadly, there have been some deaths that have been associated with that. Now, as a consequence, as part of any gene therapy trial and any clinical gene therapy delivery, along with getting the gene therapy, young people or adults will get immunosuppression to dampen down their immune response and stop that from happening. And usually that's a process where for several months there is immunosuppression given, and the immunosuppression then allows the body to gain a tolerance to the gene therapy and will no longer be needed. Because we're delivering, or the companies we're talking about delivering gene therapy into the nervous system, it should reduce the chances of a reaction, because just as I said before that there was that thick barrier that regulated and protected the brain, that also limits how the immune system can access it and cause problems. So it's estimated that about 80 to 85%, if not higher, of the gene therapy delivered either transventricularly or by a lumbar puncture will stay in the nervous system and not leak out into the rest of the body, and particularly the liver, where it would cause problems. So I think these are issues that are being addressed by the trial designs and the protocols that are being proposed. So what about the actual gene therapies that are in the pipeline? And as I said, we have 2 companies that are bringing these to trial. And as I say, if you told me that 5 years ago, I would have said, no way. These are extremely exciting times for that. So thinking about phases of studies, these are terms that people might have used and heard before, and I think it's important to consider them. So we talk about a phase 1 study, a phase 2 study, and a phase 3 study. And these are different points in the process companies go through to demonstrate that a drug is safe and it works. So phase 1 studies are first in human studies. This is when you're giving a drug or an intervention to people for the first time. Typically, you do this in healthy adult volunteers, and it's making sure it's safe and it doesn't cause any immediate reactions or problems in the body. Phase 2 studies are where you're giving the drug for the first time to young people or adults with the medical condition you're trying to treat, and essentially you're trying to demonstrate that it's safe largely in young people with those conditions, and also demonstrating that it has some beneficial effects, that it works at least in principle. Phase 3 studies are the bigger studies with larger numbers of patients, where you're demonstrating definitively that the drug works, and you're establishing more clearly what the safety profile is and what the things we need to watch out for are. Now, both gene therapy trials that we're talking about are combined phase 1, phase 2 studies. And that's because it wouldn't be ethical to give a gene therapy for a Rett syndrome or any condition to a healthy adult control person. So we have to be honest and open and say that in the young people with Rett syndrome, this is the first exposure of humans to the gene therapies from both of these studies. But the goal of these early phase trials that we're going to talk about is really around demonstrating the safety and initially demonstrating that there are some benefits. After these studies, as long as all goes well, there will need to be bigger studies with more young people to more clearly demonstrate the improvements and how much improvements are seen, and to better define the safety profile. So I'm going to talk about the neurogene study that's proposed. This is a study which is not dosed yet, but it's got approval in America to start. So the name of the trial, we talk about a novel regulated gene therapy, NGN, for a study for female children with Rett syndrome. So this study is proposed in 2 centers in the United States, and they're giving their gene therapy with the adenovirus vector that both studies are using. The target recruitment is just 5. So they're estimating that they're going to recruit 5 young people to this study. And the route of delivery, how they're going to deliver the gene therapy, is that single intraventricular dose we talked about before. The age range will be 4 to 10 years. It will be females for the first study, and their inclusion criteria include a diagnosis of typical or classical Rett syndrome, a proven MECP2 mutation, and they want stable anti-epileptic drug regime for 12 weeks beforehand. And they're asking that young people live within 2 hours drive of the center where the study is undertaken. And this is what's called an open label study. So an open label study is where everybody knows that the young person is getting the drug. And that's in comparison to what we call a closed label or randomized control trial, where you don't know whether your child or the young person you're working with is getting the active drug or a placebo. For this kind of study, these kind of important proof of concepts, and given how the drug needs to be delivered, I think everyone would agree that it would not be ethical to have a placebo trial group that go through the dosing, need to take the immunosuppression, and then have to go through all the testing afterwards. That wouldn't be the appropriate thing to do. In terms of the exclusion criteria, so the criteria that mean that a young person wouldn't be suitable for the trial. So the Neurogene study has said that normal or near normal hand function would exclude someone taking part. And that's because they're hoping and aiming for hand function to be one of the most significant things that improve. Currently, clinical significant condition other than Rett syndrome. So they want young people to not have other conditions that might cause problems. Any kind of medical condition that would mean that you couldn't have the intraventricular delivery of the drug or the anesthetics needed for that. Very abnormal development in the first 6 months of life, or a history of other genetic or neurological disorders. They would all be considered to be exclusion criteria for taking part in that study. Now, the TAISHA study, I'm going to talk about the adult study, as this is where we've got more details in the public domain. But it's important to note that the FDA in America have given approval for them to start the pediatric study, but the full details of that are not in the public domain yet. The adult study, which has started and 2 adults have been dosed, is being performed in Canada. The gene therapy is a different molecule, the different gene therapy, but it's using a very similar viral vector to deliver it. And the target recruitment, so the number of adults they're aiming for this study, is 12. The delivery, as we said, is going to be by the lumbar puncture, just 1 dose. And because this is an adult study, not surprisingly, they want adults. So it's 18 years and older to be included in the trial. And it would be young people with the female gender as well. Their inclusion criteria are very similar. So it's typical of classical Rett syndrome, a causative proven MECP2 mutation, but they also are requesting full vaccination against COVID-19 if eligible, and a willingness to receive blood products if there were any adverse events that necessitated it. And again, this is an open label study. So everybody that takes part in the study will get the gene therapy. Nobody will have a placebo for this trial. The exclusion criteria are again quite similar. So it's talking about a neurodevelopmental disorder that was independent of the Rett syndrome or another progressive genetic disorder. Any significant history of a brain injury of any cause that could cause neurological problems. Grossly abnormal development in the first 6 months of life. A diagnosis of atypical Rett syndrome. So, you have to have that classical or typical Rett syndrome to be eligible for recruitment. A change in the MECP2 gene that's not thought to cause Rett syndrome, and young people will be sort of screened by an independent genetic panel for that. Someone who requires invasive ventilatory support would not be included in this trial. And then similar to a contraindication to the transventricular route, if there's any contraindication to the lumbar puncture or the anesthesia that was necessitated for it. And they've also talked about uncontrolled seizures or status epilepticus within the first 3 months of enrollment. Now, for this study, TAISHA are proposing 2 cohorts. So the first cohort, that's which already started, will receive the smaller dose of the gene therapy. And then if there is no concerns about the safety of that, and it's for all of these studies have independent safety committees, they'll move to a higher dosing. And in both those 2 cohorts, there'll be some randomization to getting the dosing straight away or getting it a little bit later on. And as I've said, the exciting thing about the TAISHA adult study is that it's already started and there are 2 adults who've already had the treatment. And this was a very well timed presentation because actually TAISHA have updated a press release this week giving us some more details of the progress of those 2 patients. So as I've said several times now, 2 adults have been dosed in Canada in cohort 1 of this study. So an update that was received this week is that the first adult is now 20 weeks after the dose was given. So still early days, but 20 weeks down the line. What they are reporting qualitatively is a sustained improvement in key outcome measures. And they are reporting that since the last announcement, there's been some further new improvements in the RMBA, the patient global impression scale, and also of hand function. The second adult patient is now 6 weeks after the dose, and they're also reporting some qualitative improvements. And that was seen at the week 4 point. There are some other improvements that have been observed. So they're describing that patient 1 was able now to sit unassisted by week 12. And for patient 2, there's been some improvement in posture and gait and stability. For both of the patients, treatment has been well tolerated, and there's been no significant or serious adverse events. And the committee, the data monitoring committee, have given approval to move ahead for the dosing of the third patient. Now, just a quote from the release. The CEO is quoted in that press release as saying that, importantly, response was seen across multiple clinical domains in both the patients with different genetic mutation severity and phenotypic expression, including autonomic function, socialization, gross and fine motor skills. These early improvements in both patients, coupled with their sustained response through week 12 in the first patient, support the transformative potential of the gene therapy across multiple genotypes of Rett syndrome. Now, of course, this is a press release. These are early days, but these are early glimmers of some positive results. Sorry. A terrible slide to project, but just a quote from that press release taken from the principal investigator, the pediatric neurologist in Canada who's undertaking that trial. And I think the things that I would pick out that they're describing in that are, again, the safety of the dosing in the 2 patients, explaining that they've got different phenotypes, so they look slightly different in terms of their clinical picture and severity, but improvement in the key clinical domains impacting on activities of daily living. It's describing improvements in the breathing dysrhythmia. It's describing some of those improvements in the motor skills and generally some positive early signs. So I am meant to be the cynical, hard-nosed doctor who sits here and searingly eviscerates all evidence and tries to find the flaws and the problems and the worries. And I'm going to talk about that. Don't worry, I'm going to go for that cynical edge. But I would have to admit, it's impossible for me to be part of the Rett syndrome clinical community and not to see this as a moment of huge hope, of huge potential, and a shining light for the future. This is a condition that you've all lived with. And we know that there has been no treatment, nothing that affects the underlying genetic problem, the underlying disease processes. The best that people like myself as clinicians have been able to offer is symptomatic treatments that have reduced some of those symptoms. And we're on the verge now of moving into these clinical trials. Well, the Canadian trial has started, where we may actually be able to correct, at least in some way, the underlying genetic problem and improve significantly symptoms for young people. Now we have to temper this a little bit, okay? The data we have from those 2 adults is very early on. It's positive and it's reassuring, but at the moment, we have to be honest and say we don't know whether either of these gene therapies are going to work. If they do work, we don't know how much they're going to work. We don't know how much improvement we'll see and how that improvement will be spread across different domains of Rett syndrome. We don't know if it will work in all young people equally. And we don't know that yet what the safety profile is and whether we are going to face new problems and new issues caused by reactivating the MECP2 function. I'm reassured by the data I've seen in the laboratory and animal models about that regulation of the expression of the MECP2. And I don't think we're going to run into problems with too much of that. But there are lots of things that we need to be looking for, and we need to be very carefully measuring in these clinical trials moving forward. But this really is the first step in a really meaningful and really hopeful way. So my final slide before I open up to questions is this, and this is exactly what it looks like. It's a long and winding road, And guys, we're at the bottom of this, but actually we're quite a further way up than we used to be 5 years ago when I started in the Rett Clinic. As I say, these are really exciting times, but I think we really all need to bear in mind that these are trials in the early stages, and there are lots of things that can crop up, lots of problems that can occur before we get to the point where we're able to have a gene therapy as a treatment that's open to young people in the UK. As you'll see from the numbers that have been talked about recruitment, these early trials are going to be small numbers of young people with very defined characteristics. So those exclusion criteria are going to rule out a lot of young people, unfortunately. But this is how we have to start clinical trials. We have to start with defined groups of patients. What will inevitably happen, as long as we're seeing that things do improve and that the gene therapy is working, is those criteria will relax and more people will open up to it. Now, I'm actually going to stop there because I think it's important to give people as much time as we can to talk. And also, I think I've talked up until 1:40, which was exactly when I was told to talk to, which is very rare. Anyone who's seen me talk before knows I'm very good at running over. I think I'll leave this slide up if I may, just as a kind of bit of context. But I'm happy now to open it up to questions and for the team to start sharing that.
Well, can I just say thank you so much for leaving this slide up, because I'd just like for context to add in that I feel like when my daughter was diagnosed, and actually she was diagnosed just after the gene was identified as being causative for Rett syndrome, I think we were back in that mountain that's back if we're saying we're at the bottom of the
on
hill.
the other side of it.
and the whole of the community has really sprinted from over there to get to this point, and it is a moment of great hope, as you say, but obviously it means a lot more to hear it from you, Dr. Lumsden. We know how measured and careful clinicians are, and we want to make sure that you know, we're also giving a measured view of what's happening as well. I'd like to just say I felt that this was a really helpful overview of the situation, and the thing that was most helpful is to go to the beginning and provide that overall context, including things like the difference between atypical and typical Rett syndrome, and what the correlation is between the mutation, what the correlations can be between the mutations and the way that the disease presents in a person, because all of that speaks to these issues around eligibility for clinical trials. And so it's good that we've been able to put those messages across in today's presentation. Thank you. And also thank you for explaining things in such an understandable way. It feels very refreshing to me to listen to a doctor speaking about these quite complex subjects, especially around things like the role of MECP2 in such an easy to understand way. So much appreciated. Catherine, I was letting you go into the questions, so go ahead.
Brilliant, thank you. So far we've got 3 questions. There are a lot of people in the room, so if you do want to ask a question in person yourself, can you just pop your name in the chat and I'll make sure that I come to you. But so far, we've got a question from iPhone 104, whoever that is. Are the improvements that are being seen in participants progressive, i.e., does it seem that they will continue?
Okay, so I think the honest answer is that it's too early to tell at the moment. You know, whilst this is exciting, we've got this is early data on 2 participants. The first participant, we're now only getting the 20-week data after the trial. The Taysha press release has talked about some things that seem to have improved compared to the situation before the initial outcome, the initial sort of data that was put into the press releases, but it's a bit too early to see that there.
Okay.
If we think just broadly, it would make sense to me that were we to reactivate the function of the MECP2 gene, it would take a while to see all of those improvements and changes. Now, we talk about Rett syndrome as a neurodevelopmental disorder, and what people really mean by that is a disorder that affects how the brain has developed, But actually, the MECP2 gene, we know from the animal studies, if we reactivate it in an adult mouse when the brain is formed, it still has an impact on the function there. So I think we're going to see that actually improvements will happen, and that will take a while to emerge.
Thank you. Thank you. That's one of the things that goes through my mind. So Natalia has a question. The higher dose, so we're obviously dosing at low level at the moment, how much more effective are they expecting it to be based on the like the preclinical studies?
Okay, so again, we don't know. None of the companies know, none of us know that. The dosing is incredibly carefully chosen and is extrapolated from the animal data. What you're looking at is dosing that is believed to be safe, but also dosing that is likely to have some beneficial effect. So it's no good if for any drug, not just gene therapy, any drug, if a drug company goes in with too low a dose, then it'll be safe, but you'll see no benefits and that won't work.
Yeah.
Equally, if you go in too high, you might get benefits, but you're likely to get side effects.
Yeah.
So how all of these gene therapy trials across lots of different conditions, it's going in with the best estimate of what's the minimal dose to have an effect, with a plan that after the first few cases, if it's proven to be safe, you would then increase to the higher dose there. But I think that as I said, the doses that are starting doses, there's every reason to feel that we could see benefits. Of course, that does seem to be what we're seeing for those 2 patients in Canada. But to be honest, we just don't know what the optimal dose will be just yet.
Okay, thank you. Laura asks, do you know what we're seeing with the mortality risks within the mice models? Is the safety risk something that there is known a percentage for?
Okay. So in terms of mortality, it appeared to be pretty safe. I'm always wary about extrapolating too much for either of the products from the animal model to the human model. And one of the big issues there is that the problems that the gene therapy causes are due to the immune response.
Right.
And obviously the immune system in a human, fortunately, is a bit different to the immune system in the mouse there. We know that, as I alluded to in the talk, that very sadly, for some other gene therapy trials for neuromuscular conditions, there have been deaths that have been related to the gene therapy. But the difference there is that they are drugs where you're delivering them as intravenous infusions because you want them to go into the muscles, you want it to go into different parts of the body. The problems have been caused when then that protein has been taken up and expressed in the liver. The immune system has recognized that as being abnormal and attacked it.
Right.
So people may be aware that there is a gene therapy, for example, that's now clinically available for a neuromuscular condition called spinal muscular atrophy. One of the things we have to be very mindful of and watch out for is that you can get that immune response affecting the liver.
Right.
Very sadly, in young people who have received that clinically, I think it was in Russia, actually, the cases, there have been some deaths that have been associated with that.
Right.
The 2 practical implications of that are that gene therapy trials just across the board moving forward are now being much more, not aggressive isn't the right word, but more firm with their immunosuppression and actually using higher doses. But of course, that will have more impact potentially on the immune system. But for this gene therapy, because this has been delivered into the nervous system, either by that lumbar puncture or by the transventricular route, you should minimize how much is then taken up elsewhere in the body that will be more prone to developing an immune reaction.
Okay, lovely. Tony, you had a question. Would you like to unmute yourself?
Yeah, thanks for that. And just to echo from before, as always, a really clear and informative presentation. I suppose it's going back, it's my ignorance on these things, but in the trials, the dose is going to be kind of like a one-hit thing. If there's mileage in these gene therapy things, would it be a regular dosing, or is it do you just get one hit and then that's it and that'll last you for life? So just a really basic question.
So no, excellent question and very important. So the expectation is that this is a one-off dosing and that we're expecting that we wouldn't need to redose in the future.
Right.
Of course, these are conditions in the infancy. I probably didn't emphasize enough, both these trials are talking about follow-up for 5 years in the first instance, and then much longer moving on from that there. And that will be one of the unresolved questions. We've no data to suggest that the effect would wear off or you'd kind of wash out the gene therapy in any way. But that's one of the things that these longer term trials are going to need to pick up and monitor on.
Okay, thanks so much.
We have a question from James Pendergrast. Thanks, Dan. What is the time frame for completing the 2 trials in North America? And if positive outcomes are seen, what does the pathway look like for the UK?
Okay, so the time frame, I believe both pediatric studies are looking. So the Neurogene study is open to recruitment. I have to be honest and say I don't believe they've dosed, but I'm not privy to all of that information. Very understandably, companies tend not to announce it until they know things have been safe, just for how they manage the comms around that very reasonably. The pediatric study for Taysha is aimed in the US to open in the first quarter, and people will be aware, obviously, we're in discussions with the regulators in the UK for that. So that's the kind of time frame for that. Now, what happens from there depends upon how quick the recruitment is, how positive or otherwise the results are, and then what the next stages are in terms of trial design. These trials alone will not be sufficient, I would say, to convince any regulator to approve the gene therapy. And one of the elephants in the room that we have to always be mindful of is that these are not going to be cheap interventions.
No.
And so actually collectively, and this is where I think organizations like Reverse Rett are going to play a hugely important role. There's 2 aspects, isn't it? There's does it work? And for the United Kingdom, can we demonstrate to NICE that the costing is such that it's appropriate to pay for it, given that it will be a really expensive intervention?
Yeah.
So I think we're going to have a process of quite some time of expanding to bigger trials, bigger age ranges, different clinical features, collecting more robust outcome data to show that benefit, and then making the economic argument that this is a intervention which is something that should be being paid for.
Yeah.
And I think, again, one of the big things we need to do as a community is we need to find out where everyone with Rett syndrome is. And one of my pleas and one of my and I hope Rachel doesn't mind me kind of using this platform to discuss it, is I know the children we know about, we know the adults we know about, we don't know the adults we don't know about and the children we don't know about. And that's why the registry which Reverse Rett is running is so essential. It's not just about identifying young people who might take part in clinical trials. It's helping us demonstrate where young people are, how old they are, having as much information as we can to take to the regulators. So when these discussions and these economic arguments are made, we've got the best evidence to support that. So definitely one of my pleas is, if anybody is not registered, I suspect this audience probably I don't need to say that to, but just that plea to register with the Reverse Rett Registry, because it's such an important tool for this moving forward.
Thank you. Neil, I'm not sure if that answered your question, because you've asked about the approximate date when a trial could start in the UK. And I think Dan has kind of answered that by saying, there's loops still to be gone through. We're going to try and get it here as quickly as we possibly can, but we do have to tick the boxes of the powers that be. So
yeah, it's completely, Catherine. He's answered it. It's fine.
Yeah. Okay, lovely. Thank you. Mark Walls has asked, in the initial, it's a hard question, Mark, so I'm sorry if I get this, if I don't say this right. So in the initial reversal paper, there was a reference to precautions over intracranial pressure, development growth of the brain following gene therapy. Is this still a consideration or risk?
So this is a really good point and a really good question. So we know then the issue here is with the effect that the MECP2 gene has potentially on brain growth and head size. So this is not global, but one of the softer features that we're taught about to help recognize potentially young people with Rett syndrome is a faltering of head growth. So the head doesn't shrink, that's very difficult for the head to do. But when you've gone through that period of regression, the brain not growing at the rate that we would expect it to. And so the heads of young people then consequently being smaller. Now, we know that whatever happens in the brain when that regression happens, you don't lose cells. So Rett syndrome is not a disorder when cells are lost or damaged. What happens, though, is that the cells make less connections, and there's less complexity to those connections, but those cells are still there. And what none of us know is when you reactivate the MECP2 gene in a human, do you then stimulate more brain growth, and do you then get an increase in the size? Now, one of the reasons why when you're born, the bones in the skull are not fused is that in the first 2 years of life, the rate of growth of the brain is so fast, it wouldn't be possible for the bone to keep up. And so what happens when the bones fuse around that kind of 2 years of age, when they're all closing up, is the rate of brain growth is slowing down to the point at which your bones can keep up with it. But you've got a sealed container there. And so one of the things that we do need to be mindful of, and we will need to monitor for, is whether we are going to see that increase in brain size in a sealed container, and whether that could cause pressure and that could need intervention. In a way, I would see that if we do see that brain growth, that would be a positive, that we're having an impact on the brain and how it's functioning. But it's definitely something that we're going to need to be monitoring for. All of the clinical trials, repeated MRI scans are going to be part of the follow-ups. And that's an important consideration because, of course, that's likely to need general anesthetics for young people. But the burden of assessments for the initial trials is unfortunately going to have to be very high, because there are so many of these unresolved safety issues that we need to collect the best data and the best information we can. But yeah, that's one of the known unknowns, if that makes sense. What happens with the brain size if we reactivate the MECP2, and is that different at different ages?
Thank you. Natalia, I can't speak today. Natalia asked, will the pediatric trial follow the similar patterns, i.e. first patient with more severe symptoms, then followed by a milder symptoms? Will it follow the same pattern as the adult trial?
So the Taysha trial, all those details aren't in the public domain, and I'm sort of bound by non-disclosure agreements, so I can't say too much for that. What I would just say is, in principle, for all of these studies, there will be tighter inclusion criteria and exclusion criteria to begin with, and then it's likely that will expand. Just practically, if we're thinking about this issue of licensing and approval, if you do a trial only in a very narrow population, that's the population you'll get approval for. That's what none of us are interested in. What we want as clinicians, as drug companies, as a clinical community, we want to make sure that as many people as possible who could benefit from this get the opportunity to benefit from it. But to do that, we need to then demonstrate that it can work in as many young people and adults as possible. But obviously within the constraints of how you do that in a clinical trial methodology.
Okay. We have another question.
Thank you, Rachel.
How is the dosing controlled? E.g., is it via the number of viruses or amount of gene pumped in?
So it's calculated on the weight, and it's the molecular weight of the combined gene therapy to the weight of the young person. And that's all very carefully kind of controlled at the laboratory level.
Thank you. Yelda Rashid asks, if a patient is dosed with a smaller dose as part of the trial, is there the possibility for additional doses to be administered in the future?
So I think we'd have to be honest and say we don't know. That's not what my understanding of any of the proposed trial methodologies would be, but we don't know whether in the future that might be something which would occur. One of the practical challenges of repeated dosing with the AV vector is that increasing risk of an immune response there. But what I can say is that the early starting doses that have been proposed really have been proposed by both companies on the basis of what's genuinely felt to be likely to have an effect. Yeah. Because it's in no one's interest to trial at so low a dose you don't see anything. It's just not good trialing to do that.
James Pendergrass has asked, and it's a valid question because I've wondered this myself, so of course that makes it valid. James has asked, hypothetically, with money being no object, could a patient have more than one type of gene therapy, e.g. the Taysha and then the neurogene?
A very good question. I suspect it wouldn't be a wise thing to do. So first of all, I mean, aside from the practicalities of how you'd actually get hold of it and how you'd be able to deliver it there, I think the big concern would be how you would almost inevitably end up with an overdosing of the MECP2 gene dose, I think. There are very tight molecular mechanisms to control how much is produced. And it's very difficult to think that it would ever be safe to kind of combine the two there.
Yeah.
It's
I
an
have
interesting
wondered,
question because,
yes.
but it is an interesting question because for other conditions, going back to the spinal muscular atrophy, where there's a variety of biological treatments, people will be aware of what people call antisense antinucleotide treatment, which is given as a lumbar puncture.
Mm.
We demonstrated that well, I say we, wasn't of course myself involved in those trials, but it's been demonstrated that works. The gene therapy works probably better. But actually, there are trials about combining them and seeing whether they work together there. So I think it's an entirely reasonable question, but I think it's extremely unlikely to think that that would be a good idea.
Okay, thank you very much. Katie Sampson asks, if there is successful and there are no long-term immune suppressed, and they are on long-term immune suppressed drugs, are they at the same risk or less risk of getting severely unwell with their underlying condition in theory cured? I know it's really hard to predict, but I guess, yeah.
So the first thing I say is that for the immunosuppression would not be lifelong. So for the gene therapies that are in development or have been given, they are given for a period of several weeks or several months after the dose is given to give the tolerance, but it's not a long-standing kind of condition. So in contrast to something like a solid transplant, for example, where you have a lot of immunosuppression to start and then it weans down over time, but you're likely to be left on a little bit, our expectation would be there'd be a period of immunosuppression. And that does mean that there's that increased risk of infection. There are things that obviously have a small risk attached to it, but that shouldn't be a long-standing issue. And it should be a case that stops after a period of a few months.
Okay, thank you. Laura asks in relation to the COVID vaccination inclusion criteria, is that on both trials? They've avoided vaccination in case it was ever going to be seen as a contra. Do you know why they want the patients to be vaccinated?
So I don't quite, I have to be honest, I don't know off the top of my head around the neurogene because that's not easily in the public domain. I think what we have to remember is that for adults, there are the COVID infection is a much more significant risk. So if we go back to the dark days of the pandemic when we had no therapy, our intensive care units were all filled very sadly with adults who had developed a very severe immune reaction affecting their chest to the virus. And that's why it was so desperately needed and necessary to get the vaccination. In contrast, our experience with children was they didn't have an immune response. And so whilst I'm not saying that COVID caused no problems for children, quite the opposite, actually where we saw problems, it was just as a kind of typical respiratory infection in young people who would be vulnerable. So I think for the adult study, because there is that increased risk and it is a more severe illness, that's likely to be the reason why that's a particular condition for that there.
Sorry, I've got badly behaving dogs in the background. It's like I feel like I'm a BBC reporter with a child coming in a stroller. Thank you, Dan. That really does help explain it. We've got another question that says, has the speed of the acceptance of the trials like this been influenced by the rapid rollout of COVID vaccines?
I don't believe so. I think actually, from my side of things, it always feels like it takes far too long for these trials to get through the regulators. And when you see the data, you think, well, why is this taking them so long to go through that there? I think regulatory authorities just generally across the world are understaffed and it takes them a bit too long to go through these there.
Yeah.
But I don't think that I mean, it's a slightly more philosophical question. Obviously, there were, for the COVID vaccines and COVID trials, things got through the regulators much more rapidly as a kind of proof of principle. I don't think we're seeing that translating then to things speeding up for other therapies, unfortunately.
Thank you. So that's all the questions, lots of questions. Thank you so much. I had a feeling there was going to be when Dan came on, lots of questions, and I do apologise if I've mispronounced anybody's name incorrectly. That's us out of time for today. So obviously I want to thank Dan so much from all of us. Warm thanks, Dan, for how you've explained it, as Rachel said, putting it into a language that's easy for us. I'm not very good at reading medical journals. So, putting it into a language for us to be able to understand has been really, really beneficial. I do just need to remind you all that the recording will be coming out to everybody who's registered for the event. So you'll be able to watch it back in your own leisure if you want to go back over anything that you haven't understand. And I believe Dan is going to share his slides with us as well, so that, you know, we can take the time to look at it and digest the information. The next gene therapy bite-sized session, I don't know why I make it so hard for myself, is in January. We're going to give you the month of December off from seeing us. Enjoy Christmas. My first Merry Christmas of this year, but we'll be back with guest speakers from Taysha. So get registered. It's not up on Eventbrite just yet, but I believe you should all get an email from Eventbrite as soon as it's up. It's going to be up early next week. So I think that's going to be a very interesting call. So thank you once again, Dan. Thank you all for coming. Thank you for your wonderful questions. It's really, really helpful. Have a great weekend, everybody.
Thank you. Bye.
Thank you very much. Bye-bye.
Bye, everyone.